But for those who don't know, there is a catch. And the catch is who can get this financial assistance or this copay assistance. So commercial patients for most oral medications, for instance, can get copay assistance. So it's usual that one can get a drug for a nominal fee, $10 to $25 a month. And that's for the vast majority of patients. The only exception are those who have a very high level of income. For patients who are uninsured and are nationals to the United States, we can usually get the medications for free from the manufacturers. We make the case and we would get the medications. The challenges with patients who have Medicare Part D coverage. And the reason is very simple. So Stark laws were created to prevent quid pro quo and kickback type things that would not be favorable to the government as it tries to engage in purchasing services or goods. So what happens is that these laws are applied also for Medicare patients, and they preclude direct copay assistance for Medicare beneficiaries. So Medicare beneficiaries, when we prescribe a drug, the first reaction is they see that and see, wow, this is a large amount of money that I'm going to have to pay. And there's a number of steps. I won't go into those details, including what's called the donut hole, etc. Now, what we do is once we get that, we actually request support from third-party organizations. And these are usually patient foundations or other organizations that can provide indirectly this support. Now, these dollars come from the pharmaceutical company. So it's sort of a triangulation that occurs from pharma sending money to some of these organizations, which then is distributed to patients. And again, the copay assistance is the only rebate that is 100% passed on to patients. Now, people who are antagonistic to industry will see this as a nefarious practice. They will say, well, this helps keep the prices up, and this is something that should be discontinued. However, until you have a better system, I'm going to say we should not interfere with this process. Because what's going to happen is patients that need some of these life-saving medications, if they don't have a solution that is different from what currently exists, they will go without medicine. Now, I'm also very troubled by the fact that no bioethicist is calling this out. Now, this is a very vulnerable population of patients at the end of their life, where in theory this social contract that we have with insurance or with a government coverage for medications, such as could be Medicare, is actually failing them, because then it's putting that extra pressure of what people call consumerism. So the idea is that if you have something larger to be paid, if you want to have access to this medication, this will make you think twice about what you're doing. I think that's okay when you're thinking about equivalent products, but if the only product that patient needs is, for instance, lenalidomide, the Revlimid, what are they going to do? Should they forego that? Should they pass and then just go on to perhaps Melphalan? I don't think that is right, and that's why I'm disappointed that I haven't seen more of an outcry from bioethicists. And last but not least, and just as important, economists have shown that this is not a strategy that works. The reference is there on the slide for you to look into further.